Obesity is a problem that's prevalent in the United States and growing. And if you look at the CDC data for the last 20 years, you see tremendous growth in, obesity alone is about a 40% growth over the last 20 years. We see the incidence of severe obesity has doubled in the last 20 years. And if you combine overweight and obese classifications for the United States adult population, you see that over 70% of adults in the United States are struggling with their weight, be it overweight or obese. You add the fact that obesity is linked to 60 comorbidities. Think about hypertension, increased risk of heart attack and stroke, prevalence of diabetes amongst overweight. You think about those comorbidities and you understand that if we could treat some of the underlying conditions like obesity, we could potentially avoid ever seeing some of those comorbid conditions come up in a patient's health, or even take a pre-diabetic patient who's not diabetic yet, but their A1C would indicate they're pre-diabetic, get that weight under control and actually reverse that. So you think about those comorbidities, you think about the fact that there's 13 cancers associated with obesity, and we come to realize that this is a real problem in the United States that we need to start to address. It's time for payers to think about it differently, and some of the challenges that we've had associated with that is some of the stigma associated with obesity and being overweight. There's lots of stigma out there that patients that are overweight or obese are lazy. They just don't care. They're lazy. They don't care. Therefore, why should we try to help them? And the truth of the matter is that they do care. Whether that's in terms of somewhat from their perspective of acceptance as a member of society, and not being looked at as someone who's less than perfect, as sometimes we associate that with in the United States, or just the fact that there are a lot of healthcare complications that go along with being overweight or being obese. Some other stigmas that are associated would include the fact that there's this viewpoint that anti-obesity medications just don't work. And in my talk, I discussed a little bit about some of the past agents that were available, starting with the amphetamines, which were shown to be very addictive. The fen-phen craze we went through in the United States, but we found out that, hey, there's heart valve issues associated with that. So we pulled that from the market. And then, Meridia was an agent on the market that we then discovered was causing, increased incidence of heart attack and stroke. So we had to pull that from the market. So there are a lot of bad agents on the market previously. And with this newest generation of agents like the GLP-1s and specifically the Wegovy product that was approved last year, we see some highly effective agents that are showing, very, very good effects for patients in terms of weight loss, that are also, at least to this point, shown to be very, very safe. So with those agents in mind, it's time to get employers and plan sponsors to think about adding the pharmacologic agents to the toolbox, if you will, to treat obesity and to manage weight for patients. Because to this point, it's always been about health and wellness programs, diet and exercise, gym memberships, and the like, which is good. And it certainly still continues to be and always will be an important thing, right? It's always going to be important factors to have a good diet and a good exercise routine. The problem is maintaining weight loss through just those methodologies is near impossible for somebody who struggles with the disease of obesity. Adding that pharmacologic agent to the mix is really that key to sustaining a healthy weight for those patients afflicted by obesity. So I don't have any hard data to share today, but I can talk a little bit about the fact, the cost right now is roughly in the neighborhood of $1,300 a month as for treatment of Wegovy. So that would be the payer cost, about $1,300. It is a highly rebatable drug, so that's gross cost before any rebates. So I think that that needs to be looked at and considered from an employer or plan sponsor perspective in considering covering it. But the benefits associated with that, as we talked before, wouldn't you like to prevent one of your members from ever getting diabetes, the biggest driver of healthcare spend, or one of the biggest drivers of healthcare spend in your health budget is your diabetic patient population. So wouldn't it be great if you could use an agent that not only kept the patient healthy, but prevented them from getting diabetes? Or you think about a patient who is already hypertensive. They're taking, at least one, maybe a couple of antihypertensive agents. Wouldn't it be great? And you do see this. You see patients reduce blood pressure medications, either eliminate an agent altogether or at least reduce dosage. You see that also with antihyperlipidemic medications. Patients being able to eliminate those or at least reduce doses once their weight is under control. So you have all those benefits. There's 13 cancers associated with obesity. Again, wouldn't it be great if you didn't have to treat a cancer for one of your members in your patient population? You can do that in these cases by eliminating the underlying disease of obesity.